So, miliary TB is a very important disorder in which there is a widespread dissemination of tubercular bacilli, and that's, if untreated, can be dangerous to life. So, it is a fatal and seriously ill disease which has to be treated in time. So, it refers to clinical disease resulting from hematogenous dissemination of Mycobacterium tuberculosis. So, it is usually in a hematogenous manner in which the tubercle bacilli, they disseminate into the various systems, particularly the lung parenchyma. Miliary term was coined in 1700 by John Jacob Mangett, who likened the appearance of the involved lungs to millet seeds with its surface covered with small foam nodules. So, these are the millet seeds, and you can see that in pulmonary involvement this seed like appearance is there, what is known as miliary appearance. So, it can arise as a result of progressive primary infection or via reactivation. So, initial infection which can continue as miliary tuberculosis, or it can be due to reactivation of a pulmonary focus and dissemination through hematogenous route. It represents disseminated disease, that is the most important thing, usually seen in the first 6 months after the TB exposure, presents as a systemic illness with progressive fever, weight loss and other constitutional symptoms. So, miliary TB would present as pyrexia of unknown origin and with constitutional symptoms like weight loss and other unrelated symptoms like nausea, vomiting, etc. Now, it can present acutely. At that time, it can cause a high mortality. So, it can be a fulminant form. Why? Because it can involve multi-system organ failure, it can lead to septic shock, and it can lead to ARDS. So, these are the main complications of acute fulminant miliary tuberculosis. What are the subjects affected? Elderly individuals, infants, immunosuppressed patients, particularly those living with HIV. So, these are the findings. Lymphadenopathy and hepatosplenomegaly, they are often prominent, particularly easily palpable in children. Now, there is a symptom complex, and this was described in 2 series by Martin and Kim, and fever, you can note down that this is the most important symptom associated with or without night sweats. Anorexia, next common complaint, weight loss, weakness or malaise, and then symptoms pertaining to respiratory system, which is cough, dyspnea, pleuritic chest pain, etc. So, these are the respiratory symptoms. Then there are GI symptoms. What are the GI symptoms? Abdominal pain, nausea, vomiting and diarrhea. CNS involvement can lead to headache or other neurological deficits. Aches and pains is an indicator that musculoskeletal system is involved. Now, what are the basic signs of miliary TB? Fever is documented in most of these patients. On examination of the respiratory system, you can have rales or crepitations, rhonchi, pleural rub, or signs of effusion. Hepatomegaly, splenomegaly, as I told you earlier, is seen in disseminated form. Neurological signs are diminished in the mental status or signs of meningism, neck stiffness, headache, vomiting. Presence of ascites if there is Cox abdomen, presence of jaundice, skin manifestation, erythema, nodosum, etc. may be there, and a positive test for PPD may be seen in up to 40%. So, the first thing that you should examine when a patient of miliary TB comes to you is that you should go for ophthalmoscopy, that is fundoscopy. Presence of choroid tubercle is pathognomic. These tubercles appear on fundoscopic examination, yellowish lesion with indistinct border, singly or in cluster. This I described you last time. What are the lab abnormalities? Anemia with high ESR, cytopenia, and leukemoid reaction. What is leukemoid reaction? It is an increase in the leukocyte count, not because of malignancy. The lab score in that case is altered leukemoid reaction, different from CML due to neoplasia of the bone marrow, and particularly lymphoid leukemoid reaction is seen in TB. So, whenever there is suspicion of miliary TB, in patients presenting with PUO, what are the sites for culture? Bone marrow, liver, lymph node, pleura, or through a bronchoscopic biopsy. These are the various sites you can biopsy. Again the same picture, you can see variable size, ill-defined, multiple nodules on fundoscopic examination, small size, large size, they are scattered throughout the choroid plexus, choroid. And this is the radiographic images of a miliary TB. You can see disseminated forms. Some of these are calcified, and this is the lung parenchyma, the millet seed appearance. Another radiograph, disseminated tubercle, this could be the focus. So, whenever the focus ruptures into arteries, it can lead to dissemination through the arterial supply or through the venous supply, and some of these lesions are of variable size and they coalesce with each other. This is the diffuse form of miliary TB. Now, what is the differential diagnosis of multiple shadows miliary chest radiograph? Infectious disease, mycobacterial tuberculosis, and the other mycobacteria which can be non-tubercular. Fungus can also give rise to miliary type of shadows. Histoplasmosis, coccidiomycosis, blastomycosis, and paracoccidiomycosis. These are the fungi which involve the pulmonary parenchyma. Pneumocystis xerovicae pneumonia is another radiographic presentation mimicking miliary TB. Legionella, nocardiosis, Staph aureus, Haemophilus influenza, and other pyogenic bacteria. So, these are the common causes of bacterial pneumonia. Rarely they can present as disseminated chest miliary shadows. Psittacosis, tularemia, Bartonellosis, brucellosis, and melioidosis. Varicella can sometimes present as disseminated miliary shadows. Influenza, measles, in neoplastic disease, lymphomas can infiltrate the parenchyma and disseminate Toxoplasmosis, strongyloids and schistosomiasis are the parasites which can cause lung involvement, which can be a mimic of miliary TB. Now, the other part today is the examination of respiratory system pertaining to tuberculosis or to other infections of the respiratory system. So, the examination of respiratory system should start with inspection of these contents of the sputum, which could be blood, pus, etc., which could be just mucoid. What is the type of cough you should ascertain? Rate and depth of respiration. Tachypnea is a very important finding in pulmonary infection. Breathing pattern at rest, and you should also assess the muscles of respiration, whether their accessory muscles are working or not. Carefully you should examine the hands, which can show clubbing in pulmonary disorders, cyanosis, which is usually peripheral. It is central plus peripheral in congenital cyanotic heart disease, stain of nicotine, wasting and weakness of finger or the forearm, which means that the cancer is involving the lower part of the brachial plexus if it is located in the apical region. Tenderness of the wrist. So, it is an advanced form of clubbing, that is stage 4, or sometimes it is classified as stage 5, hypertrophic pulmonary osteoarthropathy, in which clubbing is the distal form. If the wrist gets involved with a synovial thickening, it is hypertrophic pulmonary osteoarthropathy, which is a manifestation of underlying carcinoma of the lung. Pulse, most of the infection can give rise to tachycardia, tremors, CO2 narcosis. Because of CO2 retention, this can lead to flapping tremor or hysteresis. Eyes can reveal Horner syndrome, indicating apical lung cancer. Eyes can also indicate anemia. So, Horner syndrome is ptosis and meiosis with absence of sweating on one half of the face. Central cyanosis can be present in respiratory failure. Hoarseness can be there if the recurrent laryngeal nerve gets paralyzed. Facial plethora is an indicator of smoking status or obstruction to the superior vena cava. Trachea must always be examined whether it is centrally placed or it is shifted sideways. So, your inspection of the chest should start with presence of scars, marks, radiotherapy marks or any operative marks. You must not forget to palpate the supraclavicular node, the chest expansion, the vocal fremators, the apex beat, and then of course carry out the percussion and auscultation. Shape of the chest and spine, presence of scars, prominent veins and cervical lymph nodes. So, these are to be noted down. You have to percuss the supraclavicular region to know the apical abnormalities. You should also percuss the back for dullness, the axilla, and of course, if there is diaphragmatic involvement, you should go for a tidal percussion, which is a dynamic percussion. Auscultate the breath sound. What are the types of breath sound? Vesicular, bronchovesicular or bronchial breath sound, which will determine the underlying pathology. So, vesicular sound is normally present. Bronchovesicular sound can be present in emphysema, and bronchial breathing is typically seen in consolidation. Then presence of adventitious sounds, which can be crackles or rhonchi, and vocal resonance. So, this is a picture showing consolidation of the right upper zone and mid zone, and such type of findings can be seen in bacterial pneumonia or tubercular consolidation. So what will be the symptoms and signs? Important symptom pertaining to respiratory system is cough, often productive if infection is involved, fever usually present if the consolidation is due to pneumonia. This type of consolidation sometimes can be due to underlying malignancy with distal consolidation. Then look for signs of hypoxemia, which can be dyspnea, cyanosis or tachypnea. So what are the signs of consolidation? Since there is no air here and this is the solidified part of the lung, so there will be presence of WP or tubular bronchial breath sound. Sometimes when there is a cavity, you can hear this distant hollow breath sound over cavities, which is known as amphoric breath sound. It mimics the sound made by blowing across the mouth of jars. So WP, tubular breath sounds, are important findings in a patient who has consolidation. So chest movement would be diminished on that side, excursion would be diminished, expansion would be diminished, and on percussion this will be dull note. On auscultation you will find typical bronchial breathing, which means that there is underlying consolidation of the lung. Continuing with consolidation, so loud dull sound when tapping on the chest over the affected area, bronchial breath sound. These are harsh, high-paced sounds in which the expiratory phase is equal to inspiratory phase with a pause, with a gap in between inspiratory and expiratory phase. Egophony is elicited when the patient says E, which sounds like A through the stethoscope. So ask the patient to say E, and this will be heard like A from a near distance. Increased TAF, that is tactile fremitus, it is enhanced vibration felt on the chest wall when speaking. So most of these spoken words can be felt when you palpate with the palm of your hand. Fine crackles, they can be heard during auscultation, often at the onset. So inspiratory crackles. Reduced or absent fremitus in extensive consolidation, fremitus may decrease, but if the bronchus is patent, you can have increase in the vocal resonance and vocal fremitus. Now what are the typical clinical findings in patients who have a pleural effusion? You can see here the angle, and this is the left sided effusion. The heart border is not discernible. And what are the symptoms? Sharp thoracic chest pain that worsens with deep breath or coughing. So initially you can have chest pain in these patients, dyspnea due to fluid compressing the lung parenchyma, cough which is usually dry and not productive. Later on it can be productive. Since this has been occupied by fluid, so there will be diminished in the chest expansion of the affected side, dullness to percussion because no resonant tissue is there in the underlying area, decreased tactile fremitus due to fluid separating lung and chest wall, and since there is no aeration here, you will find decreased or absent breath sound over the area of effusion. Egophony, E sounds like A when ausculted over. This is the portion where you can find signs of consolidation like WP, bronchial breathing or egophony. If there is less of fluid, you can see a pleural friction rub. Tracheal deviation or mediastinal shift can be seen in patients who have large effusion. So the heart may shift, the trachea may shift. This is a picture of Pneumothorax, you can see here, there is air, and as compared to the left side there are vascular markings, but there are no markings here, and this is the collapsed lung. This is what is known as passive collapse. So since the air has filled the pleural cavity, there is usually associated pleural chest pain, which is sharp, unilateral and pleuritic nature, tachypnea because of hypoxia, cyanosis, again if this is a tension pneumothorax causing hypoxemia. What are the signs of pneumothorax? Tracheal deviation to the opposite side, tachycardia, hypotension due to impaired venous return, bulging or asymmetric chest wall, decreased VF on the affected side because there is no patent bronchus here, hyperresonant, since because the lung parenchyma is filled with air, there will be a hyperresonant percussion note. Then diminished or absent breath sounds over the affected area. Now this is a picture of effusion plus an air level. This is what is known as hydropneumothorax. So air and fluid. This is what is known as hydropneumothorax. Sudden pleuritic chest pain, which is sharp, worse on inspiration, unilateral usually, dyspnea, cough, palpitation, anxiety, lightheadedness, fever or systemic symptoms with if it is associated with infection. So empyema can be there. Vital signs must be observed. There will be increase in the respiratory rate, heart rate will be increased, hypoxemia will be there, hypotension and shock if the tension physiology develops, reduced or asymmetric chest expansion on the affected side, subcutaneous emphysema, which means presence of air in the surrounding tissue, decreased VF, hyperresonance at the pneumopart and dullness over the lower part. So you can have a positional change of dullness here, that is shifting dullness may be found in patient with hydropneumothorax, and of course findings of pleural effusion like the reduced or absent breath sounds over the affected area. This is a picture showing left lung mass. You can see here collapse of the lung. Lung mass can present with variety of symptoms and signs which may vary depending on its size, location and whether it is benign or malignant. Symptoms are persistent cough, hemoptysis, shortness of breath, chest pain or discomfort, unexplained weight loss, fatigue or weakness, and of course respiratory infections which sometimes become frequent. Hoarseness because of the involvement of the left recurrent laryngeal nerve, presence of wheezing and chest wall pain or swelling can be found in lung mass. And these are the findings of pulmonary fibrosis. It's chronic lung disease characterized by fibrosis of the lung interstitium. You can see here there is pulmonary fibrosis, and on this side it is cavitation plus fibrosis. So there is a shrinkage of the lung volume leading to progressive exertional dyspnea, dry non-productive cough which can be persistent, fatigue, reduced exercise tolerance, unintended weight loss or anorexia, chest discomfort or tightness. Common signs are tachypnea, use of accessory muscles with severe disease, cyanosis because of poor gas exchange, digital clubbing, resting or exertional hypoxemia, and fine bibasilar inspiratory crackles which are velcro like crackles, usually at the lung basis, but they may be found at anywhere in unusual locations as well. This again signs of lung collapse you can see here. This is the portion of the lung collapse. So sudden onset chest pain, sharp localized shortness of breath, tachypnea, tachycardia, etc. These symptoms will be there. Decreased chest movement on the affected side because there is lung collapse already. So there are two types of collapse. One is a passive collapse, that means some pneumothorax or pleural effusion causing lung parenchyma to collapse, or absorptive collapse, like if there is an intrabronchial pathology or foreign body, this can absorb the air and cause a collapse. So decreased chest movement on the affected side would be the finding, asymmetry of chest expansion, reduced or absent breath sounds on the affected side. Now this is the summary. Most important thing: consolidation, pleural effusion, collapse and pneumothorax. You must be able to distinguish. In consolidation you will have diminished chest movement, decreased expansion of the chest, increase in the vocal fragmenters because of the patent bronchus. On percussion you will have a dull note. Auscultation you will have bronchial breathing or WP or increased VR and crackles over the affected side. In pleural effusion there will be chest bulging on the affected side, the chest movement would diminish, there will be a diminution in expansion of the lung, the vocal fragmenters would be decreased. Stony dull note is the characteristic feature of pleural effusion on the affected side, and of course diminished breath sound. In collapse of the lung there is chest retraction because the air has absorbed, movement of the affected side would be diminished, expansion and VF would decrease. VF is increased if the bronchus is patent or communicating. Dull note on percussion and diminished breath sounds because of lack of aeration. Pneumothorax, chest bulging on the affected side, diminished chest movement, diminished expansion, diminished VF because of non-aeration. The percussion note would be hyper resonant because of presence of air. On auscultation you will have diminished breath sound and diminished vocal resonance. So this is about miliary tuberculosis and about the important findings in various pathologies of the lung or pleural. So that is all for today.